Imagine you're lying in a hospital bed.
Okay.
Monitors are beeping, IVs are dripping, and there's just this constant flurry of medical staff moving in and out of your room.
Yeah, a very familiar scene for a lot of people.
Right. And it all feels incredibly tangible, right? It's like very scientific. But the thing keeping you alive right now isn't just the medicine in the bag. It's actually this invisible architecture.
Oh,
An
totally.
architecture formulated over a century ago by people who realized that to save a patient, you often have to, well, kind of ignore the disease.
I love that framing. Because that invisible architecture is essentially the operating system running in the background of, like, every single clinical decision made in that room.
Right.
While a doctor might prescribe a specific medication to attack, a specific pathogen, the overall ecosystem of your care is governed by something much, much broader.
Exactly. So, welcome to this deep dive into nursing theories. We're taking a stack of historical and clinical sources today to show you that a nursing theory is not just, some abstract academic exercise.
Not at all.
It's a systematic, organized set of statements. It's the underlying logic that tells a nurse not just what to do at your bedside, but importantly, why they are doing it.
And to understand that why, we really need to look at how these frameworks are actually built. Because every major nursing theory, like the really grand sweeping ones, they're all organized around four core concepts.
The meta paradigm, right?
Yes, exactly. In the field, it's called the nursing meta paradigm. And those four pillars are the person, the environment, health, and nursing itself.
Okay, so person, environment, health, and nursing.
Right. Any framework worth its salt has to define those four things and explain how they interact to actually facilitate healing.
Which brings us to our mission for today. We are going to trace how that meta paradigm evolved over the last 160 years.
That's quite a journey.
It really is. We're going to travel from the moral and environmental convictions of the 19th century right into the grand theory era of the 1960s and 70s.
Yeah, when things got really formalized.
Yep. And we'll look at how outside disciplines began influencing bedside care. We're going to unpack three foundational frameworks today: Nightingale, Orem, and Maslow.
The heavy hitters.
The heavy hitters that dictate your everyday reality in the healthcare system. Because, the modern hospital looks and functions the way it does because of a series of very hard-won theoretical revelations.
Yeah, that's such an important point. These weren't just shower thoughts, they were forged in crisis.
Absolutely. So to find the first major revelation, we have to rewind to 1859. And the irony here is that the foundation of modern nursing didn't actually start with nursing the patient's body directly.
No, it didn't.
It started with nursing the room.
Which is such a wild concept for the time. We are talking about Florence Nightingale, of course.
Of course.
And, she never actually used the phrase nursing theory, but she is universally credited as the founder of it.
Right, with her 1859 book.
Yep, Notes on Nursing. That book laid out what we now call her environmental theory. Because at the time, the prevailing medical view was that disease was just this mysterious, independent entity that just attacked a host.
Like a ghost or something.
Right, just bad luck. But Nightingale argued something entirely different. She claimed that the true killers were often the surroundings.
Filth, bad air, contaminated water, that kind of thing.
Exact.
Which makes the environmental theory less about, simply tidying up and more about foundational survival. Her philosophy framed the nurse's primary job not as curing the disease, but putting the patient in the best possible condition for nature to act upon them.
That is the exact quote, yes. Putting the patient in the best condition for nature to act.
But here's where it gets really interesting, because when you look at the sources, there's this massive historical misconception about her.
Oh, the lady with the lamp myth?
Yes. When most people hear Florence Nightingale, they picture the lady with the lamp during the Crimean War in 1854.
Walking the halls at night.
Right. The popular myth paints this picture of her walking the halls of the British military hospital at Scutari, providing heroic, hands-on bedside care and just single-handedly saving all these soldiers.
Which is a beautiful story, but the data tells a very different story.
Wait, okay, tell me if I have this right. The sources reveal a huge hole in that narrative because in the winter of 1854, the death rate at Scutari was hovering around a catastrophic 40%.
Yes, 40%.
So wait, if the death rate was that high, all of Nightingale's direct, compassionate, hands-on nursing didn't actually fix it. What actually moved the needle?
Well, the tragic reality of that barrack hospital at Scutari was that it was constructed directly over a massive cesspool.
Oh, wow.
Yeah, the building itself was actively contaminating the hospital's own water supply. You had like 4 miles of beds packed together in a facility that was quite literally poisoning the men.
That's horrifying.
It is, and all the bedside compassion in the world wasn't going to stop cholera and dysentery under those conditions.
So who fixed it?
A British government sanitary commission arrived in March of 1855.
Oh, yeah?
And this was a team of engineers and public health officials. They flushed out the sewers, tore out the rotting wooden floors, they dumped lime into the latrines, and physically overhauled the ventilation shafts.
The environment.
The environment. And once that structural fix was in place, the mortality rate plummeted from 40% down to roughly 2%.
In just a matter of weeks.
In a matter of weeks.
I mean, it's kind of like trying to bail out a sinking boat with a teacup when you really just need to plug the hole in the hull.
That is a perfect analogy. You cannot out-nurse a cesspool.
Right.
And that realization fundamentally reshaped Nightingale's entire worldview. When she returned to England, she spent the rest of her career functioning way less as a bedside caregiver and far more as a statistician and a sanitary reformer.
She realized the environment was the lever of survival.
Exactly. And she proved that leverage using data. She actually became a pioneer of data visualization, which a lot of people don't know.
The coxcomb.
Yes. In 1858, she published a report to the British Army featuring a graphic she called a coxcomb. It's essentially the great-grandfather of the modern pie chart.
A polar area diagram, right.
Right. Instead of wedges radiating out by angle like a pie chart, the wedges extended outward based on the volume of deaths in a given month. And she used color coding to separate deaths from battle wounds versus deaths from preventable, environment-driven diseases.
Which must have been visually shocking at the time.
Oh, the visual impact was undeniable. Anyone looking at that chart could instantly see that typhus, cholera, and dysentery were slaughtering far more soldiers than enemy cannons ever could.
Wow. And that single diagram was so effective that it helped push through sweeping military sanitary reforms, right?
It did. It actually earned her election as the first female member of the Royal Statistical Society.
That's incredible. Just a brilliant example of taking a theoretical framework, applying hard data, and changing practice.
Absolutely. Though we should probably clarify that environmental theory wasn't merely a hospital hygiene checklist.
Right. It was broader than that.
Much broader. It was a comprehensive ecosystem approach to healing. Nightingale identified 6 interconnected canons.
Let's hear them.
You've got ventilation and warmth, light, cleanliness of the room, cleanliness of the patient's body, noise reduction, and proper diet.
Meaning, like, sunlight and fresh air aren't just pleasant for the patient, they actively change their physiological state.
Exactly. They reduce stress, they fight infection.
Now, as groundbreaking as that environmental focus was, the timeline of nursing theory does something really strange after Nightingale.
It completely stalls out.
Yeah, it essentially stalls out for nearly 100 years.
It's true. Throughout the late 19th and early 20th centuries, nursing education relied on this very task-based apprenticeship model.
Like learning on the job.
Right. Nurses learned by doing, memorizing procedures, but there wasn't a distinct organized body of theoretical knowledge separating the profession from just, being an assistant to a physician.
But that dynamic finally shifts in 1952, right? With Hildegard Peplau.
Yes. Hildegard Peplau publishes Interpersonal Relations in Nursing, and she frames nursing not just as tasks in a clean room, but as a deeply therapeutic interpersonal process.
And that sparks what historians call the grand theory boom.
The floodgates opened.
The focus moves away from just the physical environment and drills down into the individual patient's capacity, which leads to this deceptively simple question: when, precisely, does a person actually need a nurse?
And that question brings us to Dorothea Orem. She took that specific question and built an entire theoretical empire around it.
So who was Orem?
Orem was a nurse and an administrator. She actually spent time working for the U.S. Indian Health Service. And in 1971, she formalized the self-care deficit nursing theory.
The SCDNT.
Right. And to grasp how her logic operates, you really have to look at 3 nested theories working inside one another, like Russian nesting dolls.
Okay, let's unpack these layers. What's the foundational layer?
The baseline is her theory of self-care. Orem posited that every human has self-care requisites. These are needs they normally meet for themselves to stay alive and functional.
Okay, like eating and breathing.
Yeah, she broke them into 3 categories. You have universal needs, which include air, water, food, and social interaction. Then you have developmental needs tied to your specific stage in life.
So an infant has different requisites than an elderly adult.
Exactly. And finally, you have health deviation needs, which are entirely new requirements created by an illness or injury.
Oh, like needing to learn how to change a surgical dressing or, monitor your blood sugar.
Spot on. So if I have those needs, the question is, at what point does the nurse step in?
Right. When does the professional get involved?
That triggers the second layer, the theory of self-care deficit. This is really the core engine of her framework. Orem stated that nursing is solely required when a patient's self-care demand exceeds their self-care agency.
Agency meaning what exactly?
Agency is your actual physical, cognitive, or emotional capacity to meet the demand.
Okay, let me make sure I've got this. If I get a paper cut, my self-care demand is super low and my agency is high. So no deficit. I just put a Band-Aid on it.
Exactly. No nurse needed.
But if I suffer a severe stroke and suddenly lose the ability to safely swallow water, my agency has just plummeted.
Yes.
So a massive deficit opens up.
And the nurse operates exclusively within that deficit. Once the deficit is identified, we move to the third layer, the theory of nursing systems.
The action phase.
Right. The nurse must choose between 3 systems of care based on the size of that gap. If a patient is fully sedated in the ICU, the nurse uses a wholly compensatory system, meaning they do everything.
Because the patient has zero agency.
Right. Now, if a patient is recovering from surgery, they might use a partly compensatory system where they share the physical tasks.
And what's the third system?
The final system is supportive educative. This is where the patient has the physical ability to do the care, but maybe lacks the knowledge.
Oh, wow. This shows up constantly in modern chronic disease care, doesn't it?
Oh, it's everywhere. Orem's logic is the direct ancestor of programs like diabetes self-management education. The entire goal is to take a newly diagnosed diabetic patient from a partly compensatory state, where maybe a nurse is injecting the insulin, to a supportive educative state, teaching them to monitor their own glucose until the deficit closes entirely.
Okay, let's pause and really unpack this, because Orem is essentially saying that the ultimate measure of a successful nurse is making themselves entirely unnecessary to the patient.
Yes, the ultimate aim is obsolescence, restoring the patient's self-care agency.
That's the exact opposite of the traditional ongoing doctor-patient relationship. But wait, Orem's idea of restoring agency to the point of isolation feels incredibly Western to me.
Ah, yes, you're hitting on the critiques.
Right, because in a lot of collectivist cultures, wouldn't family members or the broader community expect to take over the care entirely, rather than forcing the individual patient to become this independent unit of self-care?
You've hit on the most significant criticism of Orem's work. Transcultural nursing scholars point out a severe individualism problem in her theory.
It just encodes a Western bias.
Deeply Western. It assumes that the single person is the natural default unit of care. But in many global communities, illness management is a communal or family responsibility.
So forcing a focus purely on the individual's agency could actually disrupt their cultural support system.
Exactly. It's a narrow fit that assumes independence is always the ultimate goal. And there's another glaring issue with Orem's model.
Which is?
What happens when the deficit simply cannot be fixed?
Like a permanent deficit.
Right. If a nurse is caring for a patient with advanced dementia or someone in a permanent vegetative state, that patient will never regain their agency.
So the goal of making the nurse unnecessary completely falls apart.
The theory hits a brick wall. It really struggles to account for populations where obsolescence is impossible.
And if nursing can't find a solution within its own unique theories for patients like that, it forces the discipline to look outside its own borders, right?
Right.
Which brings us to the great borrowing debate.
Yes, the borrowed versus unique debate. So Orem, along with contemporaries like Betty Newman and Sister Callista Roy, they belong to the unique theory camp.
Meaning they wanted homegrown theories.
Right. They strongly felt nursing needed native frameworks built from scratch to establish itself as an independent science. But the reality of bedside care often requires pragmatism.
Yeah, you just need what works.
Exactly. When a patient is presenting with a tangled web of physical and psychological crises, nurses will borrow whatever tool cuts through the chaos.
And the most famous borrowed tool comes from Abraham Maslow.
Maslow's hierarchy.
Right. And Maslow wasn't a nurse. He was an American psychologist. In 1943, he published A Theory of Human Motivation.
And he was reacting against the dominant psychological schools of thought at the time.
Freudian psychoanalysis, which he felt was overly obsessed with pathology and what was broken in the mind.
Right. And behaviorism, which he felt reduced humans to mere stimulus and response machines, completely ignoring inner experience.
So Maslow wanted to understand human motivation, and he proposed that human needs are arranged in ascending tiers. The core logic is that lower, highly urgent survival needs will monopolize your attention before higher psychological needs can motivate you.
Right. He categorized these starting with physiological needs at the base, so oxygen, food, water, temperature regulation.
Above that is safety,
Yeah.
then love and belonging, then esteem, and finally, self-actualization at the top.
But simply listing these tiers doesn't really capture why this is so critical in a hospital.
Why is it so critical?
The real value of Maslow's hierarchy in nursing is how it explains the friction between a patient's body and their mind.
Give me an example of that friction.
Okay, a perfect example is a patient refusing a life-saving treatment, let's say a permanent colostomy bag, because they're terrified of the social stigma and how their spouse will view them. The nurse is focused on the physiological survival need, but the patient is completely paralyzed by the love, belonging, and esteem needs.
So understanding that hierarchy helps the nurse navigate why the patient is resisting care in the first place.
Exactly. It also serves as the ultimate clinical prioritization tool.
Oh, like on the NCLEX.
Yes. On the U.S. nursing licensure exam, the NCLEX, Maslow is the default logic for triage scenarios.
So if a nurse is presented with a patient who has a blocked airway, another who is having a severe panic attack, and a third who is deeply embarrassed by a new physical diagnosis,
Yeah.
who gets treated first?
The obstructed airway. Every single time. The physiological base of the hierarchy dictates survival before psychology.
So that borrowed framework has guided more real-world split-second triage decisions than almost any theory native to nursing.
Without a doubt.
But wait, while Maslow's impact is undeniable, the sources for this deep dive blew my mind regarding how we visualize his work.
Oh, the pyramid.
Yes, we all picture that iconic psychological pyramid, but Maslow never drew a triangle, and he never worked in a hospital.
It is a massive historical myth. If you actually read his original 1943 paper, there is no diagram whatsoever.
None at all.
None. He described his concepts entirely in prose.
So why is the pyramid in virtually every textbook on Earth?
It was invented decades later, in the 1960s, by business and management textbook writers.
You are kidding.
No! Corporate consultants needed a clean, simplified graphic to train executives on employee motivation. So they geometricized human psychology, slapped a triangle on Maslow's prose, and the image just went viral.
That is wild. We're all utilizing a corporate management graphic when we think of human needs.
Pretty much. Furthermore, Maslow actually revised his own theory in 1969. He added a sixth tier above self-actualization called self-transcendence.
Self-transcendent.
Yeah. But nursing schools, and honestly most other disciplines, almost never teach that updated version.
And modern research actually pushes back heavily on the strict bottom-to-top order of that borrowed hierarchy, right?
Yes, this is where it gets really fascinating. A massive 2011 study by researchers Tay and Diener analyzed Gallup World Poll data across 123 countries.
With a huge data set.
Huge. They wanted to see if human needs actually activate in the strict order Maslow proposed. And they found that while the categories of need are universally present across cultures, they do not reliably activate in a rigid sequence.
So they found that people living in extreme poverty, whose basic physiological and safety needs are constantly under threat, still actively pursue meaning, social respect, and belonging.
Exactly. The human brain doesn't just shut off its need for love or dignity simply because the stomach is hungry.
Which is such a profound realization. And that finding profoundly impacts how a nurse approaches holistic care. You can't simply treat the physical body and assume the psychological needs will wait their turn.
Right. The patient experiences all of these needs simultaneously.
Which really highlights the crux of that borrowed versus unique debate. I mean, if Maslow's hierarchy isn't even a strict law of human motivation and it was grafted onto nursing from a totally different field, does relying on it dilute nursing as an independent science? Or is insisting on theoretical purity just unnecessary gatekeeping?
Well, the consensus at the bedside leans heavily toward pragmatism.
Whatever works.
Good patient care shouldn't respect disciplinary borders. If a psychological framework gives a nurse mental clarity during a code blue, when a patient's heart has literally stopped and seconds matter, you use whatever tool works.
Pragmatism saves lives.
It really does.
Let's synthesize all of this, because the biggest takeaway from our deep dive today is that these theories are not abstract academic fluff. They are the physical bedrock of your healthcare experience.
100%. Think about it. When you walk into a hospital and observe strict hand hygiene protocols, highly specific ventilation standards in operating rooms, or the push for single-patient rooms to combat hospital-acquired infections.
You are watching Florence Nightingale's environmental logic playing out in real time.
Exactly. And when you see global health systems desperately trying to teach patients how to manage their own hypertension or heart failure at home, preventing the hospital from just collapsing under the weight of chronic disease.
That is Dorothea Orem's self-care deficit logic trying to restore agency.
Yes. And when a disaster strikes and emergency responders initiate START triage, which stands for simple triage and rapid treatment, the very first step is checking airway and breathing before absolutely anything else.
That is Maslow's hierarchy dictating the first 60 seconds of survival.
It is an invisible architecture that surrounds you.
It really is. Which leaves me with one final provocative thought for you to ponder. As healthcare becomes increasingly automated, we are rapidly introducing artificial intelligence and continuous biometric monitoring into the hospital room.
Oh, it's moving so fast.
So how is the nursing meta-paradigm going to shift next?
It's a great question. Think about the 4 pillars: person, environment, health, and nursing. If an AI system can flawlessly monitor a patient's environment, perfectly fulfilling Nightingale's vision.
And if algorithms and sensors can perfectly predict and manage a patient's physiological baseline, mastering Maslow's lowest tiers, what happens to the human interpersonal relationship that Peplau said defined the profession in the 1950s?
Right. Will our very definitions of what constitutes health and care have to evolve all over again when the machines are doing the monitoring?
It forces us to ask what it truly means to heal someone beyond just stabilizing their data points.
It absolutely does.
So the next time you or someone you love is lying in that hospital bed, look past the IV bags and the beeping monitors. Try to spot the theory. Look for the invisible logic that is quietly working to send you home.
And ideally, working to ensure you have the agency to never need to come back.
Well said. Thanks for joining us on this deep dive into the hidden frameworks of healthcare. We'll catch you next time.